is any impending perforation. And if the ulcer still doesn't respond to the above treatment, we go for a targeted therapy in the form of intrastromal and intracameral antifungals. In spite of this, still deep-seated fungal keratitis pose a challenge because of several limitations of currently available topical medications because of the poor penetration, surface toxicity, and limited spectrum, and go to non-healing ulcers, ending up in keratoplasty, which is limited by factors like graft rejection, reinfection, limited availability of donor corneas in our country. So intrastromal antifungal, which is a targeted therapy, help in deposition of antifungal drugs, increasing the better bioavailability to the ulcer, leading to healing and thus avoiding the need for keratoplasty. So in this study, we had given intrastromal origonazole for treating deep fungal keratitis. This is a prospective interventional case series conducted at Visionary Eye Hospital, Visakhapatnam from August 2022 to August 2023. 8 cases of microbiologically proven fungal corneal ulcer that did not respond to conventional therapy over a period of 2 weeks were included. And depending upon the severity, several multiple injections were given sequentially. And the patient is followed up for every 5 days, and healing was documented with serial slit lamp imaging. Coming to the procedure, voriconazole in the preservative form is available as 1 milligram white lyophilized powder in a glass vial. It is reconstituted with 2 ml of distilled water to reach a final concentration of 50 micrograms per 0.12 ml. It is then loaded in 1 ml tuberculin syringe with a 30 gauge needle. This is a video showing intrastromal vozole procedure. With a bevel up, the needle is inserted obliquely from uninvolved area to area of corneal abscess at the midstromal level, and the drug is injected, and the amount of hydration is used as a guide to assess the area which is covered. Once the required amount of drug is given, the capillary column is broken down, and the amount of drug is divided into 5 divided doses around the ulcer to form a barrage of antifungal around the ulcer. And later, post-procedure, the patient is advised to continue his topical and systemic medication. So these are the results. We have given intrastromal vozole in 8 cases, age ranging from 17 years to 60 years. Among 8, 6 are male and 2 are female, and majority are mid and deep stromal, requiring multiple sequential injections. Among 8, 6 improved well with improving the visual acuity, and 2 underwent therapeutic penetrating keratoplasty. So the conclusion of study is intrastromal vozole comes under targeted drug delivery, which is safe, effective way to treat deep recalcitrant fungal keratitis, thus reducing the need for therapeutic penetrating keratoplasty. These are the pictures pre and post injections. Thank you.
So well presented within time. Good. Next candidate, Dr. Priyamvada. Yeah, you can start.
A very good morning, dear.
Dr. Harsha can come here.
A very good morning, respected judges and one and all. I am Dr. Harika Priyamvada, presenting. I'm here to present my paper titled "Factors Predictive of Recurrence in Myelin Oligodendrocyte Glycoprotein Positive Optic Neuritis." Dr. Virender Sachdev and Dr. Sonalika are the co-authors. We have no financial disclosures. MOG optic neuritis is an antibody-mediated autoimmune disease, demyelinating disease of CNS, which consists of a spectrum of optic neuritis, encephalitis, and myelitis, but optic neuritis is the most common presentation and the manifestation. It is a distinct entity from the demyelinating diseases such as multiple sclerosis optic neuritis and NMO optic neuritis, and the incidence of MOG optic neuritis is more in Asian populations according to Arvind's study. Being acute unilateral or bilateral optic neuritis with papillitis presentation, involvement of long segment of optic nerve, being steroid responsive, recurrent episodes of optic neuritis are hallmark of MOG optic neuritis. Recurrences can occur in about 1/3 of patients with MOG optic neuritis. However, there is a limited prior literature on these aspects. Hence, we aim to identify the factors predictive of recurrences in MOG-associated optic neuritis. We use the following materials and methods. Ours is a retrospective observational study comparing recurrent and non-recurrent cases of MOG optic neuritis done at a tertiary eye care center in India, LVPI. Between the period 2018 and 2023. Though some of our patients are clinically positive for MOG antibody, we only included those cases which are serologically positive for antibody, and we preferred cell-based assay method as it is gold standard. We excluded patients seronegative for MOG as well as those are positive for NMO. We included all age groups with a follow-up of at least 3 months, since we considered at minimum 3 months is required to document a recurrence. Electronic medical records of 72 patients who were seropositive for MOG antibody were reviewed, and the data was collected for the following factors: age, gender, clinical features, best corrected visual acuity, optic disc findings, constitutional symptoms like pain on eye movements, fever, vomitings, and neurological symptoms like ataxia, seizures, headache, limb weakness are also noted. MRI brain and orbits was studied for a segment of the optic nerve involved and the brain involved. HVF pattern and mean deviation and OCT, RNFL and MGCL thickness were studied. Treatment, immunosuppression, visual outcomes, number of recurrences are all studied. At presentation and subsequent follow-ups, a total of 48 patients met the study criteria, and they were divided into 2 groups, that is the recurrent and non-recurrent groups. Most of our patients presented with long segment optic nerve involvement. The statistical analysis, we spread all the data on the Excel sheet. We used Stata software, and the p-values less than 0.5 were considered as significant. These are our results. 27 patients and 21 patients respectively are included in the recurrent and the non-recurrent groups. Our patients range from the ages of 1.5 to 61 years in both the groups, but the median age in recurrent group is 37 years, whereas 23 in the non-recurrent group. Yes, the patients in the recurrent group are slightly older, but there is no significant statistical difference between them. There was no gender predilection noted. Factors like best corrected visual acuity at presentation, constitutional or neurological symptoms, papillitis, long segment involvement or a posterior optic involvement didn't had any significant difference between the groups, but proportion of pain on eye movements was statistically significantly higher in the recurrence group compared to the non-recurrence group, and the p-value is significant, 0.04. We also found that there was statistically significant difference in the laterality, since the majority in the recurrence group had OS as the presenting eye, let's consider it as unilateral, whereas the majority in the non-recurrence group had OU, both eyes as the presenting eye. The other features are similar in both the groups. 59.3% patients were presented with pain, whereas 33% patients present with pain in non-recurrence group. These are the graphical representation of all the data, and this is the distribution of the values among them. Best corrected visual acuity has a very good improvement on treatment, and the p-value is significant within the groups. They usually presented with 2 logMAR, and the final visual acuity is 0. That means they have a very good prognosis. When we reviewed the literature, the baseline characteristics and the features like involvement of segment of optic nerve and all, they corresponded to the relevant data and were similar to the data. And there are recurrences reported in the Arvind study. The 2 studies which studied the recurrent and non-recurrent group differences are the neurological studies, which showed young adults and standard first-line immunosuppression or prednisolone to be significant, and male patients with spinal cord involvement to be significant. And hence the significance of our study is that the major strength is that it is one of the largest studies of MOG antibody disease from India. It's a comparative study and almost the first study comparing both recurrent and non-recurrent cases in MOG optic neuritis. Though the limitations are the sample size is statistically small, and it is a retrospective study. Hence, we conclude that pain on eye movements and laterality were the factors associated with increased risk of recurrence in MOG optic neuritis. Understanding the long-term relapse risk may help clinicians more informed decisions. We also extended the data, and we found starting immunosuppression has reduced the risk of relapses. However, larger further prospective randomized control trials are required to validate these observations. Thank you.
Thank you. Excellent timing, exactly.
Thank you.
Okay, thank you. Next, Dr. Harsha. Dr. Harsha is here.
Move on to the next.
Next, Dr. Surya Meenakshi. After Surya Meenakshi, Dr. Mood Mahesh. Mahesh, this Surya Meenakshi did not come? Okay, start.
Now you can discuss. You can discuss for 1 minute. Yeah. We can ask questions if required.
Good morning.
But that will be unfair for the other speakers.
Yeah, you can
Good
start.
morning, everyone. Today my topic of presentation is visual outcomes and prognostic factors in patients with traumatic cataract who underwent cataract surgery at a tertiary eye care center. Introduction: ocular trauma is leading cause of unilateral blindness in children worldwide. Aim of this study is to quantify the visual outcome in terms of visual acuity and prognostic factors after removal of traumatic cataract with implantation of an IOL. Materials and methods: this is a retrospective hospital-based study performed in a tertiary eye care center, Andhra Pradesh. Electronic medical records of traumatic cataract patients who received cataract surgery in a duration of 1 year period. Data included age, gender, causative agent, type of injury, surgical procedure done, wound location, initial visual acuity after injury, and final visual acuity. This is one of the case image showing traumatic cataract with temporal jetty 3 o'clock hours after sustaining injury with wooden stick. Results: gender distribution: out of 179 patients, 53 were females and 126 were males. Males are more involved in traumatic cataracts in our study. Age distribution: majority of the patients were 25 to 40 years age group. Type of injury: majority of type of injury is closed globe injury when compared to open globe injury. We have compared the initial visual acuity before surgery and final visual acuity after surgery, and we found that 44.7% of patients achieved the final visual status of more than 6/12. 25.13% patients had 6/12 to 6/60. Visual outcome based on location of trauma: we found that poor final visual outcome in anterior plus posterior segment involvement when compared to only anterior segment involvement. The causative agent: the most common object causing traumatic cataract was wooden stick. Corneal involvement was the most common associated ocular morbidity because we found that more common pre-existing corneal scars in traumatic patients. We have done various types of surgical procedures, and we found that highest is SSCS with PCOL implantation was performed in 59.7% of patients. Phaco with foldable IOL procedure was done in 15.6 patients, and left FA kick in 9.4 patients. Coming to the discussion, most common age group prone to traumatic cataract is 25 to 40 years. We found predominantly in males. Closed globe injury more common when compared to open globe injury, and most common causative agent is wooden stick. Most common associated ocular morbidity is corneal scar. SSCS with PCOL implantation was performed in 15.7% of patients. Phaco with foldable IOL procedure was done in 15.6 patients. Left FA kick in 9.4 patients. 54.7% patients achieved the final visual status of more than 6/12. 25.1% patients had 6/12 to 6/60. Male predominance was consistent with the previous studies from other developing countries because they are involved in outdoor activities, sports, and playing with dangerous objects. Krishnamacharya and Rati et al. Also found that wooden stick is the most common agent causing traumatic cataracts. Corneal involvement is the most common associated ocular morbidity, parallel with the LEL studies. Like similar to our study, visual acuity of more than 6/18 was obtained after surgery in 43.7% of patients in a study done in North India. Lonkor and Petrick has also shown a better visual outcome on follow-up of patients with traumatic cataract surgeries. Coming to the conclusion, traumatic cataracts causes significant visual impairment, psychological stress, and a significant economic burden. Prognostic factors being initial visual acuity, injury type, wound location, posterior segment involvement. Satisfactory visual results can achieve with the absence of posterior segment involvement and corneal scar away from the visual axis. There is a need for adequate health awareness education as well as early prevention. Early intervention with IOL implantation can achieve the good visual outcome. These are my references. Thank you.
Yeah, good presentation. You are in time. Thank you.
Thank you, sir.
Next, Dr. Chitra.
Good morning, everyone. I'm Dr. Chitra, senior resident.
Mike.
This is a study on short-term effect of 2% pilocarpine on intraocular pressure before laser peripheral iridotomy. I have no financial disclosures. Primary angle closure glaucoma is a visually more destructive form of a disease than open angle glaucoma, and the blindness due to angle closure glaucoma is much more sight-threatening. Laser peripheral iridotomy is the treatment of choice in angle closure glaucoma, and pilocarpine eye drops are used in short-term management in order to prepare the eye before laser iridotomy, as they induce meiosis and stretch the iris. Studies shows that topical pilocarpine reduces intraocular pressure in an hour, and the effect lasts up to 48 hours with an IOP lowering effect of 20 to 25% on long-term usage. The aim of this study is to study and analyze the short-term effects of intraocular pressure changes after pilocarpine installation and before laser iridotomy. The study is done at Geetham Hospital. It is a hospital-based interventional study done over a period of 6 months in 60 eyes of 30 patients with diagnosed angle closure disease. Patients diagnosed with angle closure disease on gonioscopy were included in the study, and contraindications for pilocarpine use like uveitic glaucoma, neovascular glaucoma, phacolytic glaucoma were excluded. Any contraindications for laser iridotomy were excluded. Allergy to pilocarpine were excluded in this group. All the patients underwent a careful slit lamp examination, visual acuity is noted, applanation tonometry is recorded, gonioscopy is done. First, a baseline intraocular pressure reading is taken before instilling 2% pilocarpine, and then subsequently sequential intraocular pressure readings are taken for every 15 minutes in a span of 1 hour, and the percentage of IOP reduction is calculated. This is the case sheet pro forma containing the history and the anterior segment examination. Applanation tonometer readings were taken and gonioscopy is done. Coming to the gender distribution of the disease, this study is a female preponderant study with 77% of cases being females. Age distribution of study of the disease, we can see an increasing prevalence of the disease with increasing age, with almost 56.6% of cases in the age group of 61 to 70 years. Risk factors. Among the risk factors, hyperopia was found to be the major risk factor seen in 20 of the cases, followed by diabetes, followed by hypertension, anxiety, and family history. The mean intraocular pressure values before administering pilocarpine has a mean of 18.1 with a standard deviation of 7.82. The mean of intraocular pressure after administering pilocarpine is found to be 14.8 with a standard deviation of 6.39. There is a significant difference in the mean of the intraocular pressure readings before and after administering pilocarpine with a p-value of 0.001, which is significant on paired sample t-test. So primary angle closure glaucoma is a vision-threatening condition and it needs urgent laser iridotomy. Laser facility may not be available everywhere. A sustained raised intraocular pressure may lead to painful blind eye, and pilocarpine is used to facilitate eye before laser iridotomy. In this study, we have noted the short-acting effect of pilocarpine on intraocular pressure during the laser procedure. Before the laser, a significant reduction in IOP is noted with topical pilocarpine, which is in accordance with the Yunard A et al. Study, in which they showed that there is a significant reduction in IOP post-pilocarpine use. In conclusion, topical pilocarpine installation can significantly reduce raised intraocular pressure, and they can delay the adverse effects of angle closure crisis. This therapeutic property of pilocarpine can be used in glaucoma whenever necessary, provided there are no contraindications for its use. The drug can come handy in delays of laser iridotomy or in settings where laser iridotomy is not available. It can be a life savior of vision in delays of laser intervention. These are my references. Thank you.
Yeah, good, you are in time. Thank you. Next.
Good morning. I am Dr. Sai Lakshmi, fellow at Arvind High Hospital. Today my topic of presentation is evaluation of risk factors, association and visual outcome of posterior capsular lens. My moderator for the topic is Dr. Preeti Mohanty ma'am. Cataract surgeries are one of the most frequently performed surgeries in the field of ophthalmology, and the skill design is such that it needs to provide a speedy recovery along with a good visual outcome. And any complication can happen at any step which hampers this. Posterior capsular rent is a breach in the posterior capsule of the crystalline lens during the cataract surgery, which is one of the most commonly encountered intraoperative complication. The thickness of the capsule varies from 2 to 28 microns, being thinnest at the posterior pole measuring about 2.8 to 4 microns. The capsule is thicker anteriorly than posteriorly and at the equator than at the poles. The lamellar structure of the capsule gives it the elasticity which can withhold a stretch of about 60% of its circumference. These are the various types of capsular tears which can happen and which are classified based on the location, being pre-equatorial or post-equatorial, and sometimes it might be associated with an Argentinian flag sign, or sometimes it might be a punch PCR. The aims and objectives of the present study are to evaluate the risk factors and association factors of PCR, to analyze the intraoperative steps which are more prone for PCR, and to measure the postoperative visual outcome. My study was a retrospective case study done at a hospital during a study period of 6 months in 213 cases. Cases which had PCR intraoperatively during SSCS or phaco were considered, and combined procedures or secondary IOL implantation were excluded. The data was collected from the electronic medical record, data regarding the demography, anterior and posterior segment findings, intraocular pressure, biometry, the type of surgery, intraoperative step complicating to PCR, and if there is any vitreous disturbance or secondary procedures done, and the visual acuity on POD 1 month were analyzed. These are my results. The age distribution was found to be high at around 61 to 70 years, and males and females were almost equally distributed, and laterality was seen more in right eyes, and the type of surgery more prone is small incision cataract surgery. Some associations we found in my study are 6 cases had a pre-existing glaucoma, 4 cases had iris coloboma, 5 cases had sool exfoliation, and some other associations involving include high axial length, microphthalmos, and exotropia and corneal scars. PCR in various cataracts, mostly seen in mature cataracts, brown and black cataracts, and others being hypermature, traumatic, and dense posterior subcapsular cataracts and posterior polar cataracts. These are the intraoperative steps leading to PCR. 34% was seen during cortical aspiration, and 33% during nucleus delivery, and 21% during phacoemulsification, and 12% during IOL implantation. About 79% had vitreous disturbance, and 21% did not have any vitreous disturbance. And the follow-up visual acuity was better than 612 in about 78%, and less than and worse than 612 in 22%. Discussion: elderly age group above 60 years have a thin and fragile capsule, making them more prone for rents. And in a high volume setting where majority undergo SSCS, it is difficult to conclude whether which surgical method is more prone for rents. And some associations like high myopia have more axial length, which have an adherent cataract with a mobile and flaccid posterior capsule which has a trampoline-like effect, making them more prone for rents. Microphthalmos and iris colobomas have a shallow anterior chamber and zonular weakness which can cause rents, and pseudo-exfoliation, they have a weaker zonules along with a brittle capsule, weak bag, and sometimes pore dilatation can hamper the visualization during the surgical maneuvering. And corneal opacities have the same reason, that is poor visibility, which can make the maneuvering difficult. And sometimes in advanced cataracts and advanced glaucomas or phacomorphic glaucomas, they can have a shallow anterior chamber and with a higher positive pressure that can make them more prone for rents. And brown and black cataracts and mature cataracts have a denser nuclei with a weak and thin posterior capsule. Posterior polar cataracts have an adherent cataracts, and sometimes it might be associated with PC dehiscence, which can make them more prone for rents. Traumatic cataracts can have an underlying PC defect which might be missed preoperatively, that can end up in a rent. Thank you. Thank you.
Okay. Yeah, good presentation. Next, Dr. Bhavik Panchal. There is an announcement.
Actually, we planned the general body meeting for APOS at 8:30 because of lack of quorum. We are just postponing to up to 9 o'clock. This is to announce the other APOS members. Okay, thank you.
So now the general body meeting will be 9. Bhavik Panchal is not there. Vishnu Priya. Harsha. Surya Meenakshi. And 4 absent. Now we have a lot of time for questions.
Actually, it is sad to note that presenting in Dr. Vengala's award session itself is such a prestigious thing. I'm wondering why students are absenting themselves to present this prestigious one. We were very much waiting during our times to get a chance to present. It's very sad to note. Okay, there are only 6 candidates who presented. All of them are here in this hall. Can we ask some questions or something?
Somebody
How many of you presenters are here?
All are here?
You can come to the front, all of you. I think only 2 of them are there. 3, 4, 5 of them. Okay, please sit there. Sir, can you start some questions? There's plenty of time.
I have a question for, I think Divya, no? Fungal keratitis. Yeah, did you have any complication during those injections, any perforation or something like that you noted?
You can come.
Nothing, it was.
Is there any mic?
And on an average, how many injections you needed to give to get a response?
Yeah, come to the mic. There is a mic.
So maximum we have given 3 injections, ma'am. Minimum 1 for 2 cases. One dissolved, among 2, 1 dissolved with a single dose, but other case went to a TP case, ma'am.
Okay, because one had a very nice cornea poster that in the pictures, no? That's
Yes.
why I wanted.
I have a question for Dr. Chitra. Is she here? Oh, she comes. Okay. And, from Arvind Tirupati, we had 2 similar papers, both PCO rent, one paper, same institute, same. Like I just want to know one thing from you. Both of you, you presented a sample size of 430, 400 odd and sample size of 200 odd. Were the surgeries done by the same surgeon?
Sir, no, sir. It's different surgeons, sir. One is only regarding posterior polar cataract we have presented, and other doctor presented regarding posterior capsular lens, which include all types of cataracts.
All types of
and all
cataracts. Okay, that is
study
the
period
only.
also even
that
different.
is the only difference.
Yes.
Okay. So that's what, like, I failed to understand the number of cases studied for PC rent were lesser than number of cases studied only for posterior polar. Actually, that should have, your study should have included 600 cases in that case.
Sir, actually study period was different, sir. Posterior capsular lens is studied
And
only
it's a retrospective. Both the studies were retrospective, so why did you not consider a larger sample size when it was available? Okay.
Chitra is here? Dr. Chitra.
I sent a word to come inside.
Okay.
She has gone out, I think.
Fine. And for Priyamvada, no?
We still have a lot of time.
Yes, ma'am.
That is a nice study. I mean, it's something different.
Thank
So, did you find any connection between the pain factor, the recurrence, and the visual outcome?
No, ma'am. Actually, the best corrected visual acuity was similar. I mean, all of the patient or most of the patients presented with logMAR of 2.5 in the recurrent group and 2 in the non-recurrent group. That means they presented with counting fingers and hand movements and all. But the final visual acuity was same, 20/20 in all the patients. There was no relation with the pain on eye movements and the best corrected visual acuity at the final follow-up.
And any connection with how early the treatment was instituted?
We studied that also, ma'am, but there was no significant difference that we found. Like, we studied separately the variable where we started immunosuppression in the first episode. That gave a significant difference, wherein when the immunosuppression was started, there are less number of recurrences. That was very statistically significant. But for all the cases, we give acute treatment as IV methylprednisolone for 3 days and 5 days in different people. But there was no statistically difference between the 3 days injections or the 5 days injections. And the period of chronic, long-term corticosteroids like methylprednisolone tablets, Vicelone tablets, that the time period we didn't study for how long we gave, but we uniformly we gave it on all the patients. It was uniform, like the tapering doses were given. It doesn't respect the ONTT trial.
That's what I wanted to
Yeah, ONTT trial was like for it's only for 11 days. 11 days, but no, we did like we started with 1 mg per kg for 1 week, then again just tapering 50 mg, 40 mg, 10 mg, like that. We tapered it, but when for those who patients which we thought recurrence can come, like they have a sequential pallor, I mean temporal pallor while presenting with optic neuron papillitis in one eye and temporal pallor in other eye, means there is already a recurrent episode prior. So in those cases we started azathioprine, and we also like for few cases we started azathioprine in the first attempt depending on their age, if they are very of less age, or depending on the other neurological symptoms like encephalomyelitis, seizures, ataxia. Based on these things we started azathioprine early in few cases, but overall for those patients without all these factors, for those patients where we started immunosuppression early, had less number of recurrences.
But your workup time would take some time, no, to come to this particular diagnosis.
Ma'am, this is all EMR data, so it's an observational study. We studied cases from 2018 to 2023. So overall we got 72 cases, and out of the 72 cases only 48 respected our criteria. Like we took at least minimum 3 months of follow-up, ma'am, so that at least that period is required to document a recurrence.
No, I am telling the investigations part of it would have taken time, no? So, but you institute the treatment immediately, like ONTT?
No, ma'am. What we do is, the protocol we follow at LVPI is, once the patient presents with optic neuritis and we suspect optic neuritis, we order an MRI. On MRI, we see the findings, whether it is respecting, and we also divide into whether it is respecting the typical criteria or the non-typical criteria, atypical cases. If the typical presentation is like, we take it as multiple sclerosis. If there is an atypical presentation of involvement of long segment or posterior segment or other features like chiasma involvement, then we order a blood test for NMO and MOG antibody. But we won't get the results immediately now, ma'am, but we'll start IV methylprednisolone. If we find it is typical, we'll give for 3 days. If we think it is atypical, we give for 5 days.
Yeah, nice, right.
Thank you, ma'am.
Dr. Chitra, you presented a very nice study about this pilocarpine effect for laser pyrotomy. You measured the intraocular pressure 4 times before doing the LPI. Have you taken into consideration the massaging effect that checking intraocular pressure every 15 minutes? And how the pressure reduction, was it sequentially getting lesser and lesser?
Dropping, sir.
Yeah?
Actually, we considered only the effect of pilocarpine, sir. Massage we didn't include.
No, massaging effect in the sense the very fact that you are doing ATN so frequently, and probably if you repeat it like 2-3 times, applanate it 2-3 times, that is the massaging effect, not putting the pressure. So will that interfere with the study? And second thing, I just want to make a comment, like in this study it would have been better if you had recorded a final intraocular pressure immediately after doing LPI also. That probably would have given a inference whether the immediate effect of LPI, will it reduce the pressure further, or over a period of time, say after an hour, because of inflammation, the pressure again gets back to a little bit of a spike. That would be an interesting study. Please continue this study with a larger sample. Take into this effect. What I suggest is probably instead of every 15 minutes intraocular pressure measurement, probably you can do it after half an hour and after 1 hour, and then do the LPI. Measure the intraocular pressure, say 10 minutes after LPI, and then 1 hour after LPI. That will give you a balanced, a good study. You can continue it, improve it further.
Sir. Sure, sir. Thank you, sir.
This doctor is there, Bhavik
Chitra.
No, that's okay. No, the next. Yeah, because that's why. Yeah. So because we have one more.
Okay. You please come.
Okay. We have time, so you can come.
Luckily came in time.
Yeah. And Chitra, what was the pressure range that you recorded in your study?
So, very few cases presented with acute closure cases, ma'am, and most of them they presented like half of the cases they presented with normal intraocular pressure, but angle was at risk.
So
And
they are basically angle closure suspects, not glaucoma.
all angle closure disease on a whole is included, ma'am. Angle closure suspect, closure, and glaucoma cases all are included. Thank you.
Thank you.
Yeah, your name?
My name is Dr. Bhavik.
Bhavik Panch.
Yes.
Okay, yeah,
And
please.
thank you so much for allowing.
Yeah.
Hello, sir. Good morning. So, good morning all. I'll be presenting about the efficacy of intravitreal bevacizumab as a monotherapy for treatment of aggressive retinopathy of prematurity. Okay. So, India has the highest number of preterm births, that is around 3.535 lakhs, that was measured in 2010. And if we consider up to 18,000 of these infants will go blind if not a proper screening protocol is ensured. As we know, the infant mortality rate is falling in countries like India and other developing countries, and the graph here clearly shows that once the infant mortality rate reduces, the chance of ROP or incidence of ROP rises. So ROP is a vasoprotective disease which significantly affects or causes pediatric morbidity and blindness throughout the world, whereas aggressive ROP may progress rapidly to retinal detachment if not recognized and treated early. Okay, these are just a few examples of patients with aggressive ROP where how a different spectrum of disease is explained here. Okay, so intravitreal anti-VEGF therapy has gained wider applicability in the treatment of ROP, and the efficacy is important because it helps in reduced vision loss as well as there are no side effects of the laser that are performed. So purpose of the study was that we did not have that good outcomes with laser, so we decided to start doing bevacizumab injections as a monotherapy to treat aggressive ROP, and this is our experience over a 60-month period for the treatment of aggressive ROP. So it's a retrospective case series with the main outcome measures as ROP regression and the associated with the monotherapy of bevacizumab. Demographic data including gestational age, birth weight, and ROP severity were collected, and student t-test and regression analysis was used for this study sample. So data from 476 eyes of 248 patients were included, but eyes treated only with bevacizumab were included. So out of this, a total of 298 eyes of 151 patients remained in the sample. The study period was from August 2017 to December 2022. We defined the signs of regression as pupil dilatation, disappearance or decrease of retinal vessel tortuosity, and growth of normal retinal vessels towards the peripheral retina. And treatment failure was defined as persistence or reappearance of the plush disease and neovascularization which is progressing. For recurrence, conventional laser was used to treat the recurrence. In short, if you look at the results in brief, the ratio was 82 children were female compared to 69 which was males. 31.25 was the mean gestational age, and when the infant was presented to us, the mean age at presentation or post-menstrual age was 36. So there was a gap of 5 weeks here. The mean birth weight was 1.4 kg or 1,483 grams. The mean NICU stay for this infant was 25 days, and the mean injection time, that is the post-menstrual age, was 36.03, which shows that we injected mostly on the same day or the next day when the patient presented to us. The median follow-up after bevacizumab injection was 7, that is 1 week was the median follow-up. Again, this is important because in between COVID came in and we had extended the follow-up for certain individuals or certain babies. Mean follow-up was 10 months and the mean number of visits were 8.5. Respiratory distress syndrome was the most common systemic risk factors along with the neonatal jaundice and sepsis. The recurrence post bevacizumab was around 16%, for which laser was used for in 21 eyes, and 4 cases had required a repeat bevacizumab. But majorly it was a laser therapy which was performed for such eyes. Cataract was noted in 2 eyes of such out of the total cases. Rationale for anti-VEGF is concentration of VEGF is increased in the vitreous of infants with ROP. Bevacizumab not only blocks the molecule of VEGF, but also inhibits the production of new onset anti-VEGF molecule. So better and rapid outcomes compared to laser. It was just one example what I showed. Post bevacizumab, you have complete vascularization of the retina with no laser scars, obviously. So 31 weeks suggests extreme preterm neonates, good screening across the state, as the PM at first follow-up was 36 weeks. Mean time of injection 36 weeks, that means treated early after first visit, mostly on the same day. By 1 week, we had most of the patients, more than 50% of the patient regression was already noted. And by week 6, we had 90% of patients who had complete regression of the ROP. Low birth weight and extreme prematurity are the most important risk factors for developing aggressive ROP. And 80% or 84% of children regressed spontaneously post bevacizumab. So it is safe and efficacious. There were no endophthalmitis. Only 2 cases of cataract were noted, and no long-term sequelae as noted as of now. Limitations are retrospective nature and lack of a concomitant control group. We had only one control group here, that is bevacizumab. So ROP regression rate after one intravitreal bevacizumab was 84%, which shows the efficacy of a monotherapy as anti-VEGF treatment is strongly recommended. Thank you so much. Thank you. Thank you for allowing me. Thank you. Thank you so much. Thank you.
Anybody else? Final call for them. We have 3 absentees. Any one of them are present, we can take one paper.
Harsha, Surya Meenakshi, Vishnu Priya.
That's it, sir.
Yeah, this session is closed. Thank you very much. We are all fortunate really to participate in Professor Vengala session, and we are also fortunate to be judges in this session. We are his students. We could learn something. So we wish that you will flourish in your future. Thank you. So in 10 minutes we will have a general body meeting here. So you can have a cup of coffee, and I request all of you to be here before 9 o'clock by sharp. We will start general body meeting. Today we have very scarcity of time. By 12 we have to finish all the sessions.
Please come. What's the name?
Surya Meenakshi. Okay, please come.
Good morning, everyone. I'm Dr. Surya Meenakshi from Vishaka Eye Hospital. So a 26-year-old male patient who is a resident of Araku came with the complaint of blurring of vision in both the eyes for past 1 month. He was apparently normal 1 month back and observed gradual painless progressive blurring of vision for both distance and near vision with no other significant history. His past history and everything is normal. His family history is normal. Personal history, patient occasionally smokes, and he gives history of binge desi alcohol consumption for past 5 years, and he also gives history of cannabis intake for the past 1 year. His general examination is normal, vitals are normal, and his systemic examination, ocular examination is normal. So when it comes to visual acuity, his best corrected visual acuity was 6/60 with no improvement in the pinhole, and best corrected near visual acuity is N18 in both the eyes. His anterior segment examination is normal except that the pupil was sluggishly reacting to light, and on Ishihara chart he was able to read only the control plate. So the fundus examination, here we can see that the disc is normal in size and shape, but in both the eyes there is a mild temporal pallor, and in the left eye we can see there is a hemorrhage noted in the supratemporal quadrant, with the rest of the picture being normal. Based on this, we came to a provisional diagnosis of toxic amaurosis in both the eyes, and the differential diagnosis likely to be is nutritional optic neuropathy, lesions of optic chiasma, bilateral demyelinating optic neuropathy, Leber's hereditary optic neuropathy, cortical blindness, and malingering.
The investigations done were visual field testing 30-2, SSOCT macula, OCT angiography, and visual evoked potential. So this is the single field central 30-2 visual field testing, which shows grossly depressed visual fields in both the eyes, and the OCT macula is normal, suggesting that there is no macular pathology. And we have done OCT angiography as we have seen a hemorrhage, and there is no clinical activity noted. This is the pattern reversal visual evoked potential, where we can see that the latency is near normal, but whereas the amplitude has been reduced in both the eyes. So our plan was to counsel the patient to avoid alcohol and cannabis intake and to visit de-addiction center for attaining total abstinence of these two substances, and to provide visual rehabilitation by using low vision aids. And we advised B complex for 3 months, to consult a neurophysician to rule out any intracranial pathology and to review back, and to be on regular follow-up for every 3 months. So the neurologist has advised MRI brain and the orbit, and which is normal with no significant abnormality detected in the neuroparenchyma. So based on this, we came to a final diagnosis of toxic amaurosis due to chronic substance abuse. So this coming to discussion, toxic optic neuropathy, it is due to visual impairment of the optic nerve caused by toxins, which is bilateral symmetric vision loss, papillomacular bundle damage with central or centrocecal scotoma, and reduced color vision. So these are some of the agents which cause toxic optic neuropathy, and this is mainly caused because of the accumulation of the formic acid over time, which inhibits the electron transport and mitochondrial function, which results in impaired axonal transport, and it leads to release of free radicals, which will result in retinal ganglion cell death. In our study, the patient also takes cannabis along with alcohol. So there are various studies which says that cannabinoids, they are neuroprotective and anti-glaucomatous, but there are some studies which says that cannabis intake can decrease the systemic blood pressure, and this would reduce the blood flow to the optic nerve, and it can result in optic neuropathy. And the investigations, we have done complete investigations which include complete blood picture, MRI of the optic nerve chiasma and without gadolinium contrast, and we have VEP, OCT, and these are various strategies for evaluating bilateral visual loss. So the management depends on the causative factor, and in alcohol-induced optic neuropathy, complete abstinence of alcohol with vitamin supplementation is the main therapy, and specific therapy includes giving oral thiamine tablets, folate, and multivitamins. In case of vitamin B12 deficiency, we have to give vitamin B12 injections, which is 1000 micrograms of methylcobalamin every daily until the symptoms are improved. Thereby that we can improve the, we can reduce the dosage. And in case of acute methanol poisoning, we give fomepizole or ethanol. Along with that, there are also studies which says that IV methylprednisolone would salvage vision in case of methanol poisoning. So recent studies also says that intravitreal methylprednisolone with erythropoietin would improve the condition of the patient. Take home messages: toxic optic neuropathy should always be excluded whenever the patient presents with bilateral vision loss with history of intoxication. Identifying the causative agent and avoidance of the agent would help in reducing the complications. Well-balanced diet along with multivitamin therapy will help in improving the symptoms. Regular counseling of the patient, visual rehabilitation, and de-addiction therapy with regular follow-up will help in improving the overall condition of the patient. So these are the references. Thank you.
Thank you. Good presentation.
Yes.
What was the outcome in this patient after management?
Sir, we actually, after seeing the patient, we have sent him to the neurologist, sir, because to rule out any intracranial pathology, and we asked him to review back, but unfortunately we have lost the follow-up, and the patient is not at all responding to in spite of repeated calls also. So
because you advise him abstinence.
Yes.
Okay, thank you.
Okay, sir.
So this session is completed. Thank you everyone. So we are in time. We can hand over to Dr. Madhu. So Madhu, excellent arrangements in the first session without any hitch from the management or anything, timing, everything went on well. Thank you all.